All right, so we'll start with some definitions, first of all. What we define as fever. It's not quite straightforward because if we look at different papers and different sources, we'll find different definitions of fever, actually. In London, we have adopted for our supportive care guidelines a nice guidelines definition of a temperature higher or equal to 38 degrees. Irrespective of any type of measurement, so although we recommend tympanic thermometers, but actually it's not specified in the guideline, it doesn't specify, it is not supposed to be lasting. But if we look at other guidelines, we find different definitions. After guidelines will define as fever a temperature of 38.3 degrees or higher by oral or tympanic thermometers. So this is essentially something we need to be aware of and we need to agree upon. So from now on, we'll talk about fever as we have defined it in our supportive care guidelines as 38 degrees or above in one single measure taken in any way, and knowing also the limitations of this definition. The limitations which are quite important, and somebody, Roland Armand, who is actually international leader in this, has taken the time and some fun comparing different fever definitions and checking how they modified the rate of febrile neutropenia. Now, because the rate of febrile neutropenia is what we, after a given chemotherapy regimen, is what we base other decisions such as antibiotic prophylaxis or GCSF prophylaxis. The importance of the definition of fever and this rate calculation is quite high. Neutropenia is a quite more established definition. We are talking about patients who usually have severe neutropenia, less than 5 times 10 to the power 9 neutrophils per liter. But we have to remind that the other patients will have mild neutropenia, less than 1 neutrophil, or moderate. And the other concept which is important for pediatric oncology patients is what do we expect the neutrophil count to do actually in the next 1 or 2 days since the patient is presenting to our attention, and whether we think that the neutrophil count will go down or not. How many patients are affected? It's hard to give a number, and that's why the slide is empty. And it depends really on the chemotherapy regimen which they have received and on their underlying disease. And this is something that usually people struggle a bit with, in particular people who are not pediatric oncology and don't deal with chemotherapy every day. And that's what the power of the team is great, because we often try to advise on what do we expect. So some regimens will have 80–90% of the febrile neutropenia rate, and others will have hardly any. But this is important, and we'll see in a minute why. Can we prevent actually febrile neutropenia? In the past, we used things like gas decontamination for leukemic patients. We've used antibacterial prophylaxis, antifungal prophylaxis. But let's try to put some rationale to it. So in terms of antibacterial and antifungal prophylaxis, I put here quite a general statement. Actually, the antibacterial prophylaxis has been not used for a very long time. And at the moment, we only use it for very selected patients, which are typically leukemic patients in induction, and in particular relapsed leukemic patients. So patients who have an incredibly high risk, not only of febrile neutropenia, but also of complicated febrile neutropenia with ICU admission. And for those patients, the studies have been done in North America using levofloxacin. Oral levofloxacin is not available in UK. So the statement here is quite generic. We prefer an oral fluocinolone, which is typically ciprofloxacin. We also use it to use full personal protection to go into the room of any leukemic patient. That has not proven to be of benefit. So interventions such as footwear exchange, protected environments, respiratory surgical mask, neutropenic diet are no longer recommended. the bottom line is we cannot completely prevent it. So if we cannot prevent it, then we try to manage it. And this is the initial guideline from ASCO from 2012 for the management of fever and neutropenia in children with cancer and or undergoing hematopoietic stem cell transplantation. This has subsequently been updated in 2017, and this has tried to give some guidelines to add some evidence to a complication which everybody needs to handle. So we try to add some evidence to it, and most important, we try to re-stratify. This is 2017 update. How do we re-stratify? So febrile neutropenia is the most common life-threatening complication in pediatric oncology, but we also know that it is very common, and we have all seen patients who come febrile, running up and down and completely well. How is this patient? How can I recognize if this patient is going to become very ill and needs to be treated aggressively, or if this patient has actually a low risk? Knowing that actually, fortunately, the mortality of febrile neutropenia is fairly low, and I was just going through a recent review of 3,000 episodes of febrile neutropenia with 2 deaths and 2 intensive care admissions only. So how do we identify these? And can we actually reduce the burden of treatment, admissions, and so forth, and toxicity from the antibiotics for those who are at a lower risk? So there are several now risk prediction rules that have been developed. All what I want you to, well, not all, but one really key important concept I would like you to remember is that it is based largely on clinical judgment. So your experience as pediatrician is really key on evaluating these patients, and a bit of knowledge about what is their disease and what they've been going through. Unfortunately, many of these rules don't perform well. So we'll move forward and see what do we actually do. This is another paper which deals with the same. So we have tried to put together a supportive care protocol, and we have chosen for you particularly one with certification. So I'm going to skip this. I'm going to go straight here, and then we'll go back. I mentioned a little bit of knowledge of what the patient has been going through, and a good clinical judgment. And this is what we call the modified Alexander rule. Sarah Alexander is a Canadian investigator who has done a lot of work on this. And this rule wants to clarify whether the patient is a candidate for a low-risk management, which will include potentially early discharge, conversion to oral antibiotics, or not. So age less than 1 year is definitely not a candidate for a low-risk management. These patients are more fragile. They have different metabolism, different metabolic processing of the drugs. Their disease is often more aggressive, in particular for leukemia. So these are really fragile patients who need to be carefully monitored and aggressively treated. In patients at the onset of febrile neutropenia is due to antibiotic resistance, so to the more likely presence infection from an organism which could be resistant to antibiotics. Down syndrome, these are again patients who are very fragile, very tolerating very poorly to chemotherapy. Pictured during the last febrile neutropenia episode is a surrogate for a patient who might have some sort of disimmunity or an immune system which reacts in a particularly aggressive way to infections. So the fact that the patient has required in PICU during the last febrile neutropenia episode or anyway in the past should be worrisome for us. It can also be a sign that the patient may be colonized with an organism which may expose him at a higher risk, put him at a higher risk of repeated aggressive infection. Then the diagnosis and treatment protocol, this is where we are always happy to advise. Aplastic anemia patients are our highest risk patients. And because they have, essentially because they have a really prolonged duration of neutropenia, which can last months while they are waiting for a bone marrow transplant. Infant ALL, as I said, infant ALL is a very aggressive disease, and the risk of infection is incredibly high. Patients in induction for ALL or non-Hodgkin lymphoma, relapsed ALL and AML are the patients who are who could potentially have a very serious and rapid infection. You will see that there is hardly any solid tumor patient. The only one which are present are high-risk neoplasms and relapsed solid tumors with bone marrow involvement. But even so, I would say a high-risk neoblastoma is definitely the one which has a higher risk. And then comes the clinical features, and here comes your pediatric expertise. The child who is hypertensive or presenting shock, of course, everybody will recognize this one. Rigors, altered mental status, child who is simply flat and not really reacting, not behaving normal. Mucositis, respiratory distress or compromise, new changes at the chest X-ray. It's a bit of a tricky one because we wouldn't perform a chest X-ray on any new febrile neutropenia. But if you've done it and you see changes, this is a patient who requires more attention. Or patients with a clear focus of infection or with other comorbidities. These are patients who will require a more intensive treatment. And then there are social aspects, inability to tolerate oral antibiotics, social concerns. This is our pediatric area. So with this, we are aiming at identifying at admission or at 48 hours patients who don't need a prolonged course of antibiotics, who are very unlikely to become seriously sick and require ICU admission or to have actually a fatal event, and who are therefore candidate to a lighter treatment. Now, what do we do in any case to all of our patients when they present neutropenic? So we have put at the beginning of our supportive care guidelines a big warning about the fact that a child who is unwell, irrespective of the neutrophil count or temperature, must be reviewed and must be treated as if they had an infection. In many treatments in oncology, in particular steroid treatment, can mask some of the signs of infection, including the fever. Some of the newest treatments, like blinatumomab and some of the antibiotics treated in a bone marrow transplant, will completely mask the signs of the infection. So a child who looks unwell must be treated as a child who is infected in their blood culture state and start antibiotics. The management is otherwise quite, I would say, good clinical practice for a good pediatrician. Take a good history, examine the child completely, take the blood culture. Urgent blood, so lactate has been introduced and venous blood gas based also on the sepsis 6 protocol. So we do want lactate, although not everybody would agree on the utility of it, in particular for neuroleukemic patients. So for young children under 5, urinary analysis. Just bear in mind that some of our patients will have particular risk factors, like the child who has a nephrostomy or who just had a urinary catheter inserted to have a urine collection for tumor markers. So keep in mind the more specific oncological risk factors on top of the pediatric management. And then start intravenous antibiotics within 1 hour. And that time frame, although puts everybody under great pressure of the clock is ticking, is really, really valuable for those patients who could potentially deteriorate very quickly. So everybody must have the antibiotic within 1 hour, because at that initial moment, it's really hard to discriminate the patients who are at higher risk from the others. Okay. Our supportive care guidelines still talk about 48 hours of intravenous treatment. I'm going to contradict myself in a few minutes. I'm going to show you a different way of doing things, but I would still like you to remember this is what we recommend in London: 48 hours of intravenous treatment. 48 hours is the time where in most hospitals, let's say in all hospitals, you should have better results of all of their cultures, and so you're going to make much more informed decisions at 48 hours. about continuation of antibiotics and whether you will know whether your child has a documented bacterial infection or not. You will know what has been the response of the child to the antibiotics. And so that's what happens at 48 hours, this magic number. If the blood cultures are positive, then you're going to continue based on the isolate, but you're not going to narrow the spectrum of antibiotics anyway until the child is neutropenic. If the blood cultures are negative, then you need to consider how is he clinically and whether there are ongoing fevers or not. Now, this is another, there is something which is here, is afebrile for 48 hours. And there are endless discussions on whether this could be shortened actually, and can you stop the antibiotics sooner if the child has been, for instance, afebrile for 24 hours. So we have tried to make it very crystal clear and create a clear protocol. And what I'm trying to tell you is follow the protocol, but know all the limitations of this. Okay, can you see my okay, can you see my slide again? Sorry about that.
No.
Can you see my slide?
No.
Can you see now?
Nope.
Can you see my slide?
Yeah.
Nope. Yeah.
Nope. Nope.
I can see mine.
Some say yes and some say no.
See.
Yeah, I'll go back to where we were.
Okay.
Okay. Is it good? Okay.
Yep.
Okay. So I'm trying to give you the information on what do we do, but at the same time say this is not written in stone. It's actually work in progress, and we are learning a larger and larger case series. How can we actually treat better, and how can we treat each child based on their risk level? Okay, so what do we define as low risk neutropenic sepsis? So we have just seen the criteria based on diagnosis, the treatment protocol. It's essentially with a child typically with a solid tumor or with an ALL in maintenance who presents well and there's no additional risk comorbidities. Needs also to have negative blood cultures. If they remain well, then they can be considered for discharge at 48 hours and converted into oral antibiotics. And this is what we have classified as a low-risk neutropenic sepsis. What's the frequencies of this? Actually, it is quite a large part of our patients, because as I said, also ALL in maintenance and the vast majority of our solid tumors. But we still needed to follow these rules strictly to avoid having readmissions and potential deterioration of the child. Okay. If we discharge at that point, then what we recommend is also the follow-up of patients at home. I'm going to show you later a different model of care where this part of follow-up at home has become much more predominant. But the key is that if you consider a child as low risk, this doesn't mean that you can actually discharge him home and let the family continue the treatment. You do need to verify that it's all going well and the child continues to be not only to be well in himself, so eating and drinking, no pain. So all the criteria that he had met at 48 hours, so to be considered low risk, he needs to continue meeting them to continue staying at home, and the device needs to be reviewed. Now, what's the management of those who are much more concerning to us, who are the standard risk patients? There is still quite a big variety, quite a bit of heterogeneity within this group. These are the patients who, as I said, either hematological malignancies, aplastic anemia, leukemia in induction, or any patient who presents not well, while going, needing a bolus, respiratory distress, any additional feature. You you will have given your antibiotics in 48 hours and then you reassess at 48 hours. If the patient has been afebrile, actually, and blood cultures are negative and they swell, you can actually stop the antibiotics. So your 48 hours is the time when you can identify a second group of patients who, although did not present so well, but they've done well after, and the antibiotics can be discussed. And then you are left, can be discontinued, and then you are left with those who actually are still febrile, not only did present with risk factors, but are still febrile at 48 hours. Okay, and that is where your management becomes more complicated. Now, historically, we used to do a lot of empirical work and like add antibiotics. And I hear a lot of statements sometimes like, oh, we added teicoplanin to covertoline, or we didn't really know why it had a fever, so we added, we changed to meropenem and so forth. So we're trying now to put some evidence to guide our management. And so what we're saying now is instead, do not change your antibiotics unless your patient gives you a good reason to. So if the patient is hemodynamically unstable or has a positive blood culture, then yes, follow the indications of the blood culture or upgrade antibiotics. But otherwise, you would just stay still and continue with the same antibiotics. What if the patient is still febrile at 96 hours, so 4 days after? Then you need to start considering a different type of infection. In particular, you need to start considering a fungal infection. That's also the time when you can start considering more broader investigations in terms of chest CT and abdominal ultrasound to aggressively find a focus for your infection. While so far you had done your blood cultures, you had done your urine culture, you have considered an NPA if the patient was symptomatic. So far you've gone by symptoms. Now you start thinking, well, this is actually a prolonged fever, it's 4 days of fever. You need to investigate more aggressively. And you're in particular, you're worried about fungal infections, which would not have responded to antibiotics, of course, and could be potentially life-threatening as well. So again, do not change routinely the antibiotics and do not add empirically, but look again for sources of infection and in particular start empirical antifungals. What's the role of the CRP? We do it, we all do it, we love it in London, and we do it every day often, but actually we don't know how to interpret it. And I put here a reference from Santolaya, who is a Brazilian author who has done quite a lot of work on the CRP, but it still remains very vague. Whether it is an absolute number, and in his work, Santolaya identifies a threshold of 80 as an indicator for a serious for bacteremia and a serious infection, or whether it is the trend which we often look at. But I think in some countries it is never done. Like I talk later about the work done in Australia with a febrile neutropenia management, and they never do CRP. We do it, but how to interpret? We just need to be cautious that there is no evidence around it. So what do we actually give this patient? I have not said it yet. We give a combination of antibiotics in London. And bear in mind that this deviates from all the guidelines, both NICE guidelines and international guidelines, which recommend uniformly single agent piperacillin and tazobactam. However, your choice of antibiotics is dictated by your local microbiology. And in London, we have about 25% resistance to piperacillin and tazobactam. So we recommend double coverage with piperacillin, tazobactam, and gentamicin, with a few exceptions I'm going to say. There are no doses on purpose, just use the BNF doses, because the BNF is updated much faster than our guidelines. This is also a plea to spare antibiotics, because we are already using double coverage because of the specific resistance to tazocin, which is in London. So the more we use antibiotics in a non-evidence-based fashion, the more we use in general antibiotics for those who not necessarily need or for longer than needed, the more resistances we're going to see. So ask your microbiologist, ask your infectivologist, get some guidance if you are in doubt. We are often very worried, people are often very worried about the oncology patients. So, but you're not alone, but at the same time, please do try and limit the use of antibiotics to what is really needed to avoid further resistances. What about the patients who are colonized with resistant organisms? We have VRE positive patients, we have EBSL positive patients, MRSA, and so forth. The empirical treatment should be the same as for other patients. However, in case of persistent fever or deterioration, then we need to consider adjusting the treatment. The only case in which this does not hold, and we do recommend a different empirical first-line treatment, is for patients who are colonized with EBSL, because in those cases we recommend a carbapenem at presentation of fever because they did not respond to tazocin, of course. In particular, linezolid, who is a very expensive drug, and also at the moment is still a drug with few resistances only and also quite serious side effects. So we do recommend to avoid routinely giving linezolid to VRE positive patients. Actually, the bacteremia from VRE is a rare event. So your patients can have upfront empirical treatment as all the others. With respect to MRSA, we should, as much as possible, do as per good clinical practice, do the screening for MRSA at each admission, and if it has not been done for a month during the same admission, and recommend the decontamination protocol for the patients who are positive. But if you have an MRSA positive patient, then you may want to discuss with your microbiologist, make a plan for antibiotic treatment and for escalation of antibiotics in case the patient deteriorates. But please do so in discussion with your microbiologist to have the best possible treatment for your individual patient and for all the other patients. Indication to antigen positive coverage is probably the most common change that I've seen in a patient who is febrile and does not progress rapidly is the addition of an antigram positive coverage. Either vancomycin or teicoplanin. So the indications to use of antigram positive are either an isolate from the blood culture or a focus, so a skin focus, or a patient who has an endoprosthesis. So the patients who are treated for osteosarcoma and have an endoprosthesis, for those patients need an earlier establishment of antigram positive treatment. This is the same. Antifungal we talked about. Now, what about patients who are not strictly low-risk patients, but solid tumor patients for which they've been febrile for 5 days and you're now considering antifungals? Often the risk for fungal infection is much lower. Just bear in mind that they would not have had steroid treatment. Often their neutropenic phases are shorter, and also the function of the white cells is normal compared to patients with hematological diseases. So in solid tumor patients, antifungal treatment can safely be deferred to 6-7 days of fever, should be discussed with PTC. So although the guidelines, including both the London guidelines and the international guidelines, are actually quite vague, and they use wording such as can be deferred or you could consider deferring to 6-7 days. This is something that in most cases can safely be done. And this allows you also to spare the chest CT, which is part of the fungal workup, and defer it a little bit. Most patients will definitely best by day 7 or 8. We've introduced the use of echinocandins alongside the amphotericin. Many trusts don't have echinocandins available because of their cost, but it's actually very well tolerated, in particular in patients who have risk factors for reduced renal function, like Vince patients who have Vince tumor patients or Beckwith-Wisman patients who have a single kidney. This is something that is to consider. Likewise, for patients who are undergoing autologous stem cell transplant, the use of echinocandins can be beneficial as sparing to kidney function. So this summarizes a bit what we have already mentioned. Do not change the initial antibiotic regimen empirical, just wait for your patient to change or for your blood culture to tell you something more about what is going on. Not adding routinely an antigram positive coverage unless justified. What we have not talked about is the removal of the line. Typically, the infectivologists are much faster than the oncologists to ask for a line removal. There are some infections which definitely mandate the removal of the line, and because it would not be possible to clear. And these infections can typically put your patient at high risk of rapid deterioration. In particular, Staphylococcus aureus, Pseudomonas aeruginosa, or Sanguinea are an absolute indication to remove the line. Likewise, if you have an infection of the subcutaneous tunnel of the central line, the line must be removed. Okay, we're heading towards the end of the story of our patient. How long to treat a patient? We said if the patient develops rapidly, you can actually stop antibiotics at 48 hours. Some patients just will present after the first spike of fever and not a spike again, and then they can be safely discharged at 48 hours. You can discharge as soon as you stop the antibiotics. If you have a positive isolate, then the duration of antibiotics will be dictated by what isolate you found. Something honestly is quite a bit of delay is if you remove the line, how long do you need to treat afterwards? And we do recommend usually 10 to 14 days of treatment after the line removal. But this should be discussed with your local microbiologist or infectivologist and with the primary treatment center. Okay. Now, what if the child was febrile but not neutropenic? Okay. Now, if the child has a hematopoietic stem cell transplant in the last 12 months, he or she needs to be considered as neutropenic irrespective of the count, because the immunosuppression derived from the conditioning regimen utilized, the GVHD is present, and the treatment of the GVHD can last much beyond the normal neutrophil reconstitution. Okay, but if the child has not had a hematopoietic stem cell transplant, then that's where your clinical judgment is the most important. If the patient is well, then does not actually need necessarily IV antibiotics. They do need to investigate if there is an infection, so they still need blood culture, they need urine culture if appropriate, they need an MPA if appropriate, but they don't necessarily need antibiotic treatment. You can always, again, discuss either with your primary treatment center or with microbiology. Okay, so the conclusion from this is culture. Please try to try to work on what your clinical assessment is, what your microbiological findings are. Try to find the source of the fever and try not to react empirically to the fever, which is in the end a number. Stay still unless your patients give you a good reason not to, and talk to your microbiologist. And now I want to show you a different way of doing things that we are trying to introduce in UK, thanks to the coronavirus, which has actually created some good discussion around this. The objective is safely reduce the duration of admission and safely reduce the duration of antibiotics. And bear in mind that this is actually implemented already at Great Ormond Street, but not in the other primary treatment center of London. So this is based on work done in Australia, the Royal Children's Hospital of Melbourne, where this low-risk febrile neutropenia program was implemented in 2018. So 336 children with cancer have been assessed, and 39%, so quite actually a good proportion, identified as low risk. And this is what the program has resulted. So a significant reduction in the duration of hospitalization, which implies significant cost saving. they have modified, they used a risk stratification tool to define these 39% as low risk, which include the three criteria, which is chemotherapy intensity, platelets, and the total white cell count. And this prediction rule has been validated to predict bacterial infection. This is I'm going to show you the rule when I come back. Sorry. Okay, here it is. So preceding chemotherapy more intensive than ALL maintenance. This is meant to be extremely conservative. So in this rule, they're considered as not low risk, not low intensity chemotherapy, everybody who had something different from ALL maintenance, essentially. Total white cell count below 0.3 and platelets under 50. Platelets under 50 are simply surrogated to indicate they still not complete bone marrow recovery. And that gives a score which goes from 0 to 3, where patients who had a score of 0 were very low risk for a bacterial infection. And they were sent home after 4 hours of observation. Patients with a score of 1 were considered just low risk and were admitted for up to 24 hours. And then patients with a score of 2 or 3 were actually the patients who, in which the bacterial infections were found in the end, and they were admitted for at least 24 hours. Now, what they have identified is also that the majority of your blood cultures become positive by the 24 hours. So if you apply your prediction rule at 24 hours, it is actually a lot more sensitive in identifying patients who are going to have a bacteremia and require IV treatment and the more prolonged hospitalization, compared to applying your prediction rule on day 0 at presentation, when you have very limited information on your patient. So they used this risk stratification rule to identify patients who could safely be transferred to home-based care. Now, we have to bear in mind about the availability of resources. So I have to acknowledge that they do have still a home care system which allows nursing visits daily and potentially administration of IV antibiotics at home. So they need to have a low score to be and fulfill the home-based care eligibility criteria, which resembles very much the Alexander rule, and they are here listed. So we are back to the same, a little bit about the cancer, the disease, and what they have received, and a lot of good clinical assessment. So patients who had patients need to be in remission, whether they are leukemia, lymphoma, or a solid tumor in remission. ALL in induction, infant ALL, same patients as before, were completely excluded from this management. Expected duration of neutropenia less than 7 days. And this is where you may need some input from your primary treatment center. And then again, no confirmed focus of infection, no medical complications, no severe sepsis at presentation. And the social factors, availability of a 24-hour caregiver, of a phone, ability to go rapidly to a hospital within 1 hour in case of deterioration or changes at home. Suggested antibiotics. This really depends on the local epidemiology. So in Australia, they use the piperacillin tazobactam as initial IV treatment, and then they discharge on ciprofloxacin and the coamoxiclav. But this really depends on your epidemiology. This is just the schedule of follow-up and the criteria for the family to contact the PTC again. Okay, they have set up a patient education resources, including information sheets, a readmission letter, a home observation chart, which we see here. So although it may seem very complicated for the patients, it has actually found great acceptability from patients and healthcare providers equally. So this is a different way of working, and I just wanted to walk you through a couple of case studies and see what would we do and how can we re-stratify these patients, and what would we do if we had these patients coming through our A&E doors. So Lila is an 8-year-old girl with rhabdomyosarcoma who is very close to a hospital and presents with a temperature of 38.5 degrees, runny nose, had a recent gastrostomy, and this 9 days after I phosphomide and doxorubicin. These are her admission bloods with a low hemoglobin of 57 actually, and neutrophils of 0.03. So how would she classify into with this Australian score? I'm going to do it for you. So she had definitely, any comments? Anyone wants to try? Definitely she had a chemotherapy more intensive than ALL maintenance, because ifosfamide and doxorubicin is quite aggressive and will cause mucositis. And will definitely cause the neutropenia. So that she has already. She has, the total white cells are more than 0.3, and the platelets are more than 50. So she qualifies as a score 1. So she's actually low risk according to this rule. But is she eligible to be discharged home after 24 hours? So having gone through all these risk factors, actually, it appears that yes. Now, we will probably not do it, but it's important to, at the moment, but it's important to bear in mind that she has a really low risk of becoming a sick patient requiring intensive care, and so we can consider her for early discharge and continuation of oral antibiotics at home. Now, this is James instead, who's a 3-year-old boy with B-cell ALL in induction and presented to A&E with 39 degrees and no other symptoms, platelet on 78, and hemoglobin of 86. She was started on tizocin and gentamicin, and then overnight he actually improved and had the best to a 37.6 degrees. Is he a low risk? Anyone wants to try? Okay, let's try and do it. So he had definitely more intensive chemotherapy than ALL maintenance. He had a white cell count more than 0.3 and platelets above 50. But he is, despite his low score, he is definitely not eligible for an early discharge because he is a leukemic patient in induction. So that is what makes him at a higher risk of complication from his fever, and he should remain as inpatient, be treated with IV antibiotics until afterwards for at least 48 hours, we say in our supported care guidelines. Although, as we said, we're working on potentially considering a 24 hours criteria. So he will stay in hospital. So these are the conclusion from this Australian experience, that 39% of their patients were identified as low risk for brain neutropenia. They were able to be treated as with a home-based treatment with significant reduction of the cost of care and improved quality of life. The clinical decision rule has been validated and has subsequently been validated outside Australia, in Switzerland and other European countries. And we should be very careful in using decision rules which must be validated in the local setting with taking into account local epidemiology and logistics. As we said, we unfortunately don't have such a home care system as the Australian one. It is a low-risk rule and not a no-risk rule. So there must be a safety net, and actually about 15% of the patients were represented to the hospital and were reassessed, although not all needed a readmission. And there is ongoing work on better and better risk stratification of patients to give each patient the treatment and duration of treatment that they require in the appropriate setting. And I'd be happy to take your comments. Hello?
Is this new guidance available to DGHs via the internet, or where can they get hold of it?
So it has been discussed in each PTC. So GOSH has implemented it, but in the current situation, GOSH has actually absorbed a lot of the work of the DGHs. In our PTC, we are discussing it, how to implement it, and it's currently available on the CCLG website, but it's available in the form of a guideline without the details of antibiotic, in particular oral antibiotic treatment recommended at discharge. So we are working on if and how to implement in our PTC.
Just looking at the chat, there's a question from the PICU generic account. How was the risk stratification determined? Is it a known stratification or a new one?
Sorry, say it again.
So the question is written, how was the stratification determined? Is it a known one or a new stratification?
It's a new certification because this introduces the Australian score based on pre-chemotherapy and total white cell count and number of platelets. So this is an additional layer to risk stratify. And then the eligibility criteria for early discharge are very, very, very similar to the modified Alexander rule that we used. So I would say this introduces one extra layer of certification. It's definitely new.
Thanks. Just one more question from the chat as well. Asking, is this in operation at the moment in the UK?
It is, each center is considering it. It has been elaborated by the CCLG Supported Care Special Interest Group, and it has been proposed for consideration to all the centers, but each center will have to decide if they want to accept it and implement it or not. And I know that Leeds and Birmingham are working on it, and I know that GOSH has already implemented it, and we are working on it as well, but it's center dependent, essentially. I think it would be really interesting to see the results of the service evaluation, which comes attached to this guideline, because then we'll have UK data on how it has been implemented and how has been the readmission rate, the representation rate, and so forth.
Thanks.
Thank you. Any other questions? Thanks. Thank you very much. Bye.